Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. So the patient who attended with a weeping, discharging, infected right ear. This is the examination video of the patient's healthy left ear, and this is the patient's right ear, so this is the infected one. So they have what we call otitis externa, which is an infection of the outer ear. The ear has been just discharging for the last few days, and near the entrance where we were there, all the skin is crystallised, solidified, and that was quite tricky to remove. The patient will need some medication for that, actually. It's become very scabby. And the otitis externa, not only have they got a discharge, also a weeping ear, so all this is what we call otter ear, all this gunk, discharge, debris, but the ear canal is also inflamed. They've got edema, swelling of the ear canal, which can make it, did make it difficult in many ways, not least I'm trying to insert the instrument into the ear because there's limited space. So I'm trying to use a standard Zollner suction probe here because this otter ear debris, dead skin is quite thick. So just trying to lift it off the canal wall, and I can just about insert the Zollner suction probe in. So what has caused this infection for the patient? Now, it's not the first time they've come. They have come previously as well, about 18 months ago. And I suspect it's just because the patient got water in their ear. We discussed strict water precautions last time. However, they did get some water in this ear recently, and that seems to be the trigger. So I think now I'm still using a standard Zollner suction probe. And you can see the bottom of the ear canal. You can see the inner layer of the canal, the fresher layer of skin, as we take this debris off it. So the patient will need some antibiotics. I'm just using a fine end suction probe now, and we're near the eardrum. You can just peeling this skin back on the posterior canal wall. So that came out in a nice slither, a nice sheet. So just trying to clear the entrance a bit, and we're now on the roof of the ear canal. It was quite a rancid smell. When people have got ear infections, it is let out a lot of olfactory evidence. It's quite acidic. The patients themselves obviously don't generally notice the smell because they're somewhat acclimatised to it, but the patient did make reference to that their family could also smell the infection when they were close by to the patient. So just on the anterior canal wall now, so this is the front part of the ear canal, you can see how I've just gently lifted this dead infected skin off the canal wall. I think I'm just going to use the big sucker in a minute, the standard Zollner suction, to remove that. So we do got to be careful because the patient obviously has got an infection, and they attended, and one of their symptoms upon attending was otalgia, which is earache. So we've got to be really, really careful. So just to the right here, so on the anterior canal wall, the patient has got a bit of a swelling. It'll become more visible in a moment. And as a result, what I'm going to have to do is bend the tip of this fine suction probe so we don't make contact with the swelling. I think it'll become more apparent in this shot. So a bit more medial, so towards the eardrum, just to the right here. So the suction probe is at the moment obscuring the view, but it will come in view in a moment. So as I'm trying to remove this debris off the inferior recess, the suction probe is ever so close to the bony part of the ear canal on the right, just there. I don't know if you can see it's protruding on the bone on the right hand side is protruding inwards. And I think at this moment I am going to bend the suction probe so I can avoid making contact. You can see that now, the bend on the suction probe, so we're mitigating making contact as much as possible. And I'm slowly now just lifting this debris off the eardrum, and fortunately there, as I was coming back out with the suction probe, the skin peeled all the way from the eardrum to the entrance. some people may be asking the question, why don't we just flush the ear out? Well, one of the reasons why we don't flush the ear out, well, you're not meant to be flushing the ear out to begin with. And more so if you've got an infection. So in the UK, if anyone is performing ear irrigation or syringing where they are flushing water into the ear, a contraindication to that is an infection of the ear, even if the infection has resolved, but it's been less than 6 weeks. I believe it was 6 weeks. You shouldn't be performing ear irrigation because that can, once again, trigger an infection, a repeat infection. And as I mentioned right at the beginning of the video, the patient getting water in the first place is the most likely cause of them developing this otitis externa. So in the UK, irrigation is where the water is flushed into the ear at a controlled rate. The specialist can regulate the flow of water and the pressure either by a foot pedal or a dial on the machine. Syringing is what I believe in America that's still being practiced. That's been banned in the UK. So syringing is when an old-fashioned metal syringe is used to squirt water at extremely high pressure into the ear. The reason why that's been banned in the UK is because it did lead to not only many ear infections but also perforations of the eardrum. So therefore suction, the method we're using now, has become the gold standard in the UK. There was another technique called dry mopping where a piece of cotton wool is attached to the end of an ear hook or Jobson horn, the serrated end, and you kind of spin the cotton wool into the ear. Again, that's not really practiced much in the UK. I think it's still in America. That can cause some grazing of the ear canal, and also you get all these fibres that come loose in the ear and the bacteria can kind of start breeding on that. So the eardrum is visible straight ahead, but because of their otitis externa, it's featureless. You can't really see the landmarks. So I'm just gently trying to remove some of this debris that's just slightly behind that swelling, but it wasn't enough space, and I was just really being cautious not to make contact at the many parts. So I just left that. There was just a very minimal, non-significant amount of debris just hiding behind that swelling. So this is at the entrance, and you can see it's become more scabby, it's become really dry. The patient will need some prescribed treatment for this, some cream or some spray. Already referred them to their doctor. And you can just see underneath that, as I'm removing that, it's become a bit scabby, so I just kind of decided to leave that. I don't want to over-work that and expose the deeper tissue of the ear canal there. So I've more or less cleared the ear canal deeper near the eardrum. We're just going to mop up near the entrance now, so we're probably on the cartilaginous portion here. And if you just want to remind yourselves of what it looked like before, I'm going to try and add a little clip of the patient's ear at the beginning of the procedure, so you can do a kind of a before and after comparison. The patient could be mention that they were hearing significantly better, but I did advise them to still follow through with their prescribed medication. They don't want to get complacent because the bacteria is still present. When we suction the ear, the bacteria is still there. We're just clearing the ear of any obstruction, any debris, so it allows the medication a better chance at healing their ear. And of course, again, we reminded the patient to avoid water entering the ear because that appeared to be the trigger in this instance, like the first time the patient attended about 18 months ago. So again, just some dead skin at the base of the ear canal near the entrance now, just gently lifting that away. So you can see all the fresher, healthier skin that lines the ear canal there, which was previously hidden by all the discharge and infected debris. So that's the patient's eardrum. I hope you enjoyed that video, guys. Take care and speak to you soon. Bye.